Hi everyone, this is Kyle Deal, one of the members of the Economics Advisory Group. I'm a chairperson of that subcommittee. So for the people that are already here, as you'll see, we have I've got my screen shared, and we'll start the webinar. It's right at 8. And what typically happens, or what will happen, is that people may come and go. People may come in and out of the meeting, and that's fine because the discussion will be recorded and it'll be available afterward. I'll give you more information when we finish up on how to access that. Okay, so it's 8 o'clock, and we'll go ahead and start on time here. Welcome everybody who's part of the RFS and YPS membership is joining us for this webinar. Let me do a few housekeeping things before we jump in the discussion about our paper and hear from Dr. Duzak and Dr. Golding. This webinar is brought to you by the Economics Advisory Group. The Economics Advisory Group is a subcommittee of the Resident and Fellow section and is supported by the ACR, so we're very appreciative to be able to have this format to discuss topics and papers, and also to have our esteemed ACR faculty who give us their time. So really appreciative for that. The topic of discussion today is tackling RVUs for the early career radiologist. We'll have the live webinar, and we'll hear from Dr. Golding and Dr. Duzak, and then it'll be available for recording for review later, recorded in a format that'll be reviewable later for the people that can't make it. The article that we're discussing, let's go back, is Measuring and Managing Radiologist Productivity. There's a two-part article, part 1, Clinical Metrics and Benchmarks, and part 2, Beyond the Clinical Numbers. I link to those articles in our welcoming email, and I'll post a picture of the article name in just a minute. So if you don't have the article in front of you and you want to look at it, all you have to do is Google it, because when you find the article, it's available for ACR members once you log in. So you find the article, you log in with your ACR credentials, and you'll be able to pull it up if it's something that you want to read during our discussion. So going forward, just another bit about the Economics Advisory Group. Dr. Silva is our coordinating faculty advisor. There's 14 members. It's a subcommittee of the ACR RFS. So as we approach the national meeting this year, if it's something that you're interested in joining, there'll be we'll take on new members at the national meeting, and anyone who's interested is welcome to join. Right now there's 14 members. So Casey, Brett, and Cindy, although I'm the one talking during the webinar, they did a lot of work to help put this together, so I really appreciate their help. So before we jump in, there's some instructions. The only microphones that are active are myself, Dr. Golding, and Dr. Zacks. So if you have a question, if you're listening, you have a question, you can type it into the question box. You'll have it on the little command module that comes with GoToMeeting. And I'll try when I can to pull those up and present those questions for everybody to hear if you have them. And then the other questions that we talk about represent those that were submitted either to me over Twitter or by email or to our other EAG members. So we got a lot of good feedback there. So hopefully we got a discussion that's relevant to everybody. Okay, so without further ado, our two faculty members who are joining us to discuss the article, Dr. Duzak, Council Vice Speaker of the American College of Radiology and Professor and Vice Chair of Health Policy and Practice at Emory, and also Dr. Golding, Dr. Lauren Golding, Vice Chair of the Macro Committee at AACR and is with Triad Radiology Associates. So Dr. Duzak, will you give us a little background of what your background is with RVUs and why you wrote this article, and just an intro?
Sure. First, thank you, Kyle, for inviting me. Thanks to the Economics Advisory Group for putting this together. It's really an honor to speak with you all and share the virtual stage with Dr. Golding. It's a topic that I've been interested in for a long, long time, and just a little bit of background on me. I've been at Emory for 5 years, and but before that, I spent 18 years in private practice. Was a president of a group that was probably one of the first groups in the country, somewhere around 2001, 2002, to really start getting into some issues related to measuring physician performance in a very rigid and rigorous way. Our group, for a variety of reasons, and we all learn things over time, and it's been almost a couple decades. I would have done things quite differently, but we, like a lot of other groups, focused on a surrogate measure of physician work, largely focusing on the relative value unit, which is a measure, and I know Dr. Golding's much more of an expert in some of this than I as a attendee at the RUC meetings. Anyway, we'll share some stories over the course of our hour about why I think it worked in parts, why I think overall it's a poor metric as your exclusive metric of physician performance, both from my experience of private practice as well in academics. And so with regard to the question about the article, Kyle, Larry Muroff and I, and Larry is, a big thought leader in radiology practice management. When I was in private practice, spent a lot of time doing consulting with a lot of private groups and had a lot of sidebar discussions with Dr. Muroff because he and I were both seeing with our client practices a number of the same issues, and we realized, gee, we should just get this stuff out there, tell some of our stories, get people educated, and put out our warnings. And so the article's dated, again, like a lot of things, I would have done things differently if I were writing it today with what I've learned since then, but hopefully we'll catalyze our discussion for this evening.
Roger that. Yeah, so article posted in, Dr. Duzak referencing article posted in 2011. And yes, there's been changes to the environment since then, but I mean, if you read through it, it's still totally relevant. Before I jump into more, Dr. Golding, will you tell us your approach here and what, as a chair of macro committee, as being part of RUC meetings, what your take is on RVUs and how we measure physician work with RVUs?
Sure, Kyle, and I also want to thank you for inviting me. Thank Rich for joining me and all of you guys that are spending your evening talking about RVUs tonight. I kind of did the opposite of Rich, so I was in academics for a little over 2 years at Wake Forest, right out of training, and then I switched from academics into private practice. And part of that was because at the time there wasn't a whole lot of opportunity to get involved in the business side of things in academics, and I really liked that part of radiology and medicine. So in my new practice, I kind of assumed the role of one of the business leaders. And as part of that, I started looking at this RVU thing, looking at reimbursement, really started to understand what was then a new legislation in MACRA. And And then that led me to getting in touch with a lot of the leaders at ACR and the Economics Commission. And now I'm the vice chair of the macro committee, and I'm on the reimbursement committee, as Cal said. So I go to the RUC meetings, which we'll talk about and explain at some point during this webinar. But it gives me a little bit of a different perspective on an RVU instead of just a measure of productivity and within our practices. It's really the cornerstone of how we get paid. And I think that's really an important thing for residents and fellows and all radiologists to understand that how the system works, how the relativity works, how those values are assigned, and how important that is for our structure. It's a different discussion, I think, on how that's used at a practice level to measure people. Measuring people is always a tricky thing to do, and especially if you use one number, one standardized number. I think there's a lot of intricacies to that, and we'll get into that in our discussion tonight too. In my practice, we do measure RVUs. We post them. Everyone knows their own individual average RVU performance. There's a public publication of the RVUs, but they're not named. Often we can figure out who they are, but there's no incentives or financial penalties for RVU production right now. We do have a pretty sophisticated system of doing it where we standardize basically the work slot. So if you do a Tuesday morning pediatric radiology work list, then you're measured against all the other people that do a Tuesday morning pediatric radiology work list. So that gets rid of a little bit of the complication that we'll probably discuss later tonight with measuring people against people. But that's a little bit of my background, sort of where I'm coming from in my own private practice work and a little bit of my policy work. And I'm looking forward to the discussion tonight.
Perfect. Thanks so much. And again, really appreciate you both being, joining in for the webinar. So I think it's a perfect segue. The most general topic, but something that we've got to talk about, and particularly because there may be people that aren't, acquainted with RVUs, is how do we measure physician work? What is an RVU? Why is it problematic to use an RVU, to use RVUs to define our work? So that's an early topic in your paper, Dr. Duzak. So, can you help us out there? What's an RVU? Why is it problematic to use RVUs to define our work?
I'll share my perspective, and I'm not sure if you want Lauren and me to each tag team these, or you have specific questions.
If you will tag team them, I'd appreciate it. Both perspectives are interesting, and give it round out a discussion.
Yeah. So a little bit of background on the Medicare system, because I think the measure, as Lauren alluded to, of the RVU was never ever designed for measuring individual physician productivity. So if you go back to about 50 years ago, when President Lyndon Johnson signed into law the Social Security Act that established the Medicare program, essentially a single payer system for eligible individuals, 65 or older individuals with end-stage renal disease, and a few other sort of carve-outs that get you into the Medicare program. The federal government got into the business of providing healthcare insurance for people all across the country. And so just like any insurer, then they need to say, how are we going to establish our fee schedule for these? At that point, the American Medical Association had pretty much started just recently around then, establishing the CPT system, current procedural terminology, which is the coding system by which all of our services are billed and reimbursed. And Medicare had no national average fee schedule. So when they rolled out the program initially, they paid physicians based upon something called UCR, usual, customary, and reasonable. And they basically said, and a lot of it was a political compromise to get into it, is we're going to continue to pay doctors what they would have gotten paid usually and customarily or reasonably within their own markets. And so if you're a neurosurgeon in Manhattan, New York, you're probably going to command a better price than, say, a family physician in Manhattan, Kansas for that. But what wound up happening then, of course, is that there was all sorts of variation in a national program, and then the government basically said, hey, we need some standardization. They commissioned a health economist at Harvard named Bill Schau to create this system, the RBRVS, the Resource-Based Relative Value Scale. And basically the goal of this system was to create a benchmark of a lot of measures of relativity, all the factors that go into each CPT code, to say, here's the RVU basis, the relative relative value units associated with that. And there's different components. There's a work component, a practice expense component, and a malpractice expense component. And the goal was to establish some relativity with these that Congress then could each year establish its own conversion factor, which multiply, you take RVUs times conversion factor, and it gives you dollars, which is how much Medicare would spend, give or take a few pennies with some geographic variation. And so that's the big picture of sort of how these were designed. They were designed to create a national fee schedule, but they never were designed to say, you know, Rich Duzak and Lauren Golding are in the same practice, and, you know, she's doing these cases and I'm doing these cases, and this was a benchmark to compare the two of us. It's never been validated for that purpose and certainly was not designed for that purpose. And so that's where I think a lot of groups run into trouble.
Yeah, it hits us hard too because radiologists have such micro-specialized scopes of practice. You know, like, for example, IR is very different from MSK and it's very different from neuro. There may be a different call pool. There may be totally different work list, but we're all, like, for example, in a private practice group, we're all billing the same.
Yeah, Kyle, one thing I'll just add to Rich's excellent description there. So he mentioned that RVUs are based on a couple of factors, and I think he said this, that CMS uses a mixture of time and intensity to come up with the RVUs. So there's a fairly concrete number to how many minutes it takes you to do an exam or procedure. That's broken up into a pre-service, like looking up prior exams, that kind of thing, an intra-service, actually reading the report or doing the procedure, and then a post-service time that's editing the report, communicating findings to a referring physician or a patient. So that's the time part. The intensity is a lot more subjective, and I think that's where the variable that's really hard to use in productivity measurement, because if there's a certain number of hours in our day, and a bare minimum may only take it may take a long amount of time, but the intensity is fairly low compared to like a complicated brain MRI, even though it takes you a lot longer time. So it's hard to compare that RVU because it's hard to factor in that intensity component. Does that make sense?
Makes sense.
Yeah.
Well, it brings up a good point, which is how, and maybe this is more opinion than fact, but how should we divide up the work? Should there be a neuro, like, for example, your high level neuro cases, those are probably going to be handled by a neuroradiologist, but the head CTs, are they picked up by the whole group? Are they shared among everybody, so the neuro person can focus on the MR, which is going to produce more RVUs, or is it something that, because it's in the neuro field, it's something that is knocked out by the neuro staff? Does that make sense? Do you think there's a right way of dividing that up? I think it's very practice dependent. I think every single practice is different. I think it's different between academics and private practice, obviously. In academics, obviously, generally the neuro people read all the neuro. In private practice, it depends on your staffing. If your group has a really big, bolsterous neuro section, then maybe they can handle that. And my group neuro reads all neuro MR, most outpatient or complicated CTs. Head CTs are read by the ER person. Whoever's in the ER is picking this off. So it's more of kind of a site of service distribution than strictly what they're being read. But other practices do it very differently, and I'm not sure there's a one-size-fit-all solution there. I gotcha. You know what? The perspective. I mean, most of the listeners or viewers of this are going to be, residency, fellowship, young and early in practice. So the perspective is, what kind of group am I? How's it broken down in the group that I'm joining? What's my job going to be? I mean, making it relevant to an N of one. How do I make sure I'm pulling my weight with regard to RVU? So I'm speaking for myself, but I'm speaking for a lot of my colleagues too, that's where the focus ends up being.
Yeah, I think that's an important perspective there, which is, what is your priority? What's the right thing when you're choosing a job, particularly for the young career folks or the rising career folks on the call. I've got a perspective here that, a lot of folks are always focusing on, how do we fix it so that the RVUs are fair? I step back, and I think that's really the wrong question to be asking, which is, letting the metrics drive your behavior. Ultimately, and there's a variety of different groups and a variety of different cultures, depends upon the size and the level of expertise and subspecialization of your group. But I think the goal of all of our groups should be able to provide the best care that we possibly can. That doesn't necessarily mean super subspecialized. There may be some timing issues, as Lauren alluded to. You may not need your neuroradiologist to be reading the head CTs. You may want your person on deck for the emergency department to be interpreting them as well. And so I think it's more important to say, how do we drive the best care rather than how do we make the RVUs fair and make ourselves slave to this arbitrary metric that was never designed for this purpose. What do I mean by that? I've heard groups say, well, you know what, I'm, a musculoskeletal or I'm a GI person, but I should be able to dip into the MRI brain work list so that I can get my RVUs up. I think that's the wrong thing to do unless you're a super subspecialist or you've got expertise in some practices. Now, you may be the best person to do it, and that's great, but don't do it for the RVUs as well. And then you figure out, sort of as Lauren has said that her group does, is, you compare the person who's doing the abdominal CT to the person who's doing the abdominal CT. I tend to do a lot of biopsy drainage, lower end IR procedures. You don't want to compare me to our neuroradiologist or to, our IRs that are doing TIPS and interventional oncology. My RVUs will never match in that scenario, but compare me to the people that are doing my slot as well. Am I keeping up? Am I able to handle the work? So it really has to be done in a very thoughtful way that does not inhibit patient care.
Yeah. So and now we jumped right into the nuts and bolts of using an RVU in our practice. One thing I do want to switch gears back to some of the more national discussion, because of course that's something that only you guys can give us an insight to. I do have one more question though about the specifics, which is regarding cherry picking. And you mentioned that phrase in your paper, cherry picking and anti-cherry picking. We're saying cherry picking is picking up cases that are quicker, easier to read, higher RVU producing, and maybe avoiding cases that are going to, it'll be a slog to get through and maybe lower RVU producing. But really, rather than define it, I was interested in your perspective on anti-cherry picking. How is that done, and is that successful? What do you think?
Well, I'll jump in since I think Larry and I probably coined that term, and it's a pretty sad term that you have to coin that. And Lauren is in a practice now where she can jump in and talk about how her group deals with some of this. So we went naively almost 20 years ago, just dove in on the deep end of the pool into this RVU type of thing, and then started saying, we hadn't really thought through all of these pieces, some of the nuances that Lauren and I were just talking about. Everybody's got to be there. So what we found out that there was a huge, if you will, point spread of folks. Now, there were two reasons for some of that. Some people were just inherently slower. There were a couple people, at least arguably, who weren't working as hard as other people. That's certainly debatable. And then there also was the natural subspecialization of the group. Even though everybody in the group at that point was a generalist to some degree, people concentrated on their own areas of expertise. But what we did find was that there were particularly one person who was at the left end of the bell curve, and at least the word on the street was that probably because this person wasn't as fast a worker as other people, developed a reputation for sort of going into the work list, sort of double clicking to open a study and then say, oh, post-op brain, this tumor, it's been radiated, click close, as opposed to double click it. Oh, it's a 20-year-old with a headache. Sure, I'll dictate this. So that was sort of the cherry picking. So what we actually had to create then as a rule, because anytime you create metrics, humans will start doing their things, we actually had to create a whole series of anti-cherry picking rules. which was, if you open a study, you own the study, and we're going to be tracking those types of things. And at that point, you have to find an appropriate person in the group to help you if you say it's too complicated. So it's sort of like the tax laws. You create these tax laws, you get a new tax attorney, they come in, they find some new loopholes, and then the IRS squeezes it down. So that's sort of the process that we went through.
Yeah, to add to that, in my practice, we in general don't have too much of a problem with cherry picking. We have a couple people who will grab all the head CTs off the ER list and leave the plain films and bellies because they know that those are faster RVUs. In general, our rule is that you read by timestamp. So if you're the ED person, you're taking the oldest to the newest without exception. And the same thing within subspecialties. If you're reading off the neuro list, you go from oldest to newest. And that is generally followed. I think it brings up a good point that as you guys are looking at practices and interviewing for jobs, it's probably a good idea to ask several people in the group if they feel like the people in their practice are team players. And in most cases are people really trying to do the right thing and pitch in to get the work done. I think that's variable in practices. I'm lucky, I think, in my group, we're very busy, and we generally, there are people who are inherently slower, but I'm not sure out of 40-some radiologists, I'm not sure we have any that I would label as just slackers. And I know that those people exist, but the fewer you have in a group that you're joining, the better. And if you mention something that in an interview and you hear some mumblings and grumblings and they say, oh, well, this person, that person, this person, it's kind of a problem. You may want to think about that if you're considering joining that group versus you ask the same question to a different group and they say, oh no, everybody's, for the most part, a team player and they're all going to hop on the list and help out. It's a little bit of a mentality thing. Some of it's human nature to want, if you're being tracked by numbers, some of it's human nature to want your numbers to be higher. And we all are high performers and we like to see that RVU ticker go up. But if there's some basic rules in the practice and a general mentality of helping out, I think you can usually avoid that being too toxic. The other question to ask your group is how are they, your potential group is how are they using, if they track RVUs, how are they using it? It's a little bit bigger deal if they're just tracking it, nobody knows about it, or if they're tracking it and publishing it, or if they're actually using it to penalize people. I know several groups have RVU kind of a standard deviation, and if you're 2 standard deviations outside of the mean, then they take off days away from you, or they take financial penalties away from you. And then those stakes are getting really pretty high, and then I think human behavior changes a lot more, and that team player mentality kind of takes a dive. It doesn't apply as much anymore. So those are important questions to ask when you're interviewing or looking at potential job changes or new jobs. I think that's good to know about a group. So
I appreciate that synopsis. That's a good overview. And then, yeah, that's where, when you're coming into it from the training end and you're finishing training, I mean, a lot of times all you know is, I want to be efficient. I want to take good care of my patients. I want to join a good group. I want to pull my weight. So those are good questions to fall back on and ask maybe in an interview setting. So I appreciate that. I dove right in there, but I want to tap into it. Dr. Golding, you're a resource here for the RUC, and you can give us information that people might not even know what that is. So could you tell us, and that it relates to RVUs for sure. So could you tell us how the RUC works? What is that? What's the RUC? And give people a better understanding of how all this stuff is generated.
I'll try. I do have several hours. This is not a simple process. I'll give you a really brief overview. So the RUC, it stands for the Relative Value Update Committee, or the RV Relative Value Scale Update Committee. And basically, they have the task of assigning RVUs to CPT codes. And it's a body that's made up of a bunch of different specialist representatives. Radiology has a permanent seat on the RUC. Zeke Silva is our current RUC panel member. And there's other specialty societies, primary care, other specialists, and then members from CMS are on the panel. It's an entity that's constructed by the AMA, so the AMA runs it. If you think the AMA doesn't have a lot of power anymore, they run both the RUC and the CPT process, so they still do have some control over those processes. In general, what happens, so most codes have been assigned a value by now by the RUC. There's different screens, and codes are caught on these screens, and they can be things like an increase in utilization or high expenditure codes, or codes that someone has nominated as potentially misvalued. In fact, more recently, in the most recent physician fee schedule final rule, one of the insurance companies nominated several codes as potentially misvalued, and head CT was one of those. So it's kind of interesting to see the direction of where these potentially misvalued codes come from. But if a code's identified on one of those screens, then it comes before the RUC. The specialty society has to express a level of interest. So if it's a code that radiologists perform, then we say, okay, that's us. And then we take it on, and we have to make a decision on what we're going to do with it. We can choose to survey it, which means we send out surveys to our members, and they fill out these documents saying, okay, this is how long it takes me to do this. This is how intense I think this is. This is how I think it compares to other codes, relative-wise on the in the relative value scale. And then those surveys and that data from the survey, the RUC advisors and the RUC team, we take all that data, we prepare an argument of why we think a specific RVU value should be assigned to that code. And we go before the RUC panel, we present our argument, there's lots of questioning, sometimes it's very, it can be rather contentious and a little bit like a rugby match, but we present our argument, and then eventually the RUC votes, and they say yes or no to what your recommendation was, you decide on a value. That's not the end of it. The RUC recommendations go on to CMS. Generally, CMS follows the RUC recommendations, but sometimes they don't. Lately, they've had a little bit of issues with some of the RUC recommendations for radiology codes. The final authority really is in the final rule, and CMS will say, we agree with RUC recommendations, these are the RVs we want to assign to these codes, or we disagree and this is what we think it should be. So that's sort of an overview of the process. There's lots and lots of nuance to that in the steps along the way, but in general, that's what the process is, and that's how an RVU is assigned to a CPT code.
So you mentioned that radiology has a permanent position on the RUC, and that it's Dr. Silver right now. What constitutes a permanent position, or like what decides if a specialty has a position on the RUC?
It's just in the RUC composition. I guess when the AMA constructed it initially, there's 4 rotating seats. I want to say there's 17, but this is in my talk for Saturday, so I need to look it up. I can't remember exactly how many there are. I'll find it when somebody else is talking here. But there's a certain number of seats, and those are permanent. So orthopedic surgery has a permanent seat. Neurology has a permanent seat. Neurosurgery has a permanent seat. Primary care, pediatrics, geriatrics. So different specialty societies have permanent seats, and radiology is one of those.
Gotcha. And when you also mentioned surveys, now when there's a survey, like let's use that head CT as an example. When there's a survey, I would imagine, tell me if I'm wrong, it's the goal is to reduce cost when there's a survey.
Anytime a code is nominated as potentially misvalued, the underlying, CMS wants to save money. The whole process is really to save money. So they have brought forth all these codes trying to squeeze down the RVUs as much as they can in effort to save money. So you're exactly right. The other thing to remember is the word relative in this whole thing. So there's a fixed pot of money and it's budget neutral. So if radiology manages to quote win our arguments and get more RVUs, that's at the expense of everybody else that's sitting in that room. So all the other specialties, they're through the conversion factor, are going to see their income go down. So I think that's what leads to some of the underlying contention. And it's actually a lot of fun, but there, if you think about it, the stakes are pretty high. So when we're making our arguments, the other people around the table see that as a direct threat to their income. So let's see, you asked me about something else and I got distracted. Oh, the head CT and the survey. So yes, their goal is to reduce the payments for anything. And in general, our goal is to either maintain. It's really hard to get an increase in value, although we have done that a couple of times. Specifically recently for the diagnostic mammography code, we were able to present data and argue that the post time, and that in the typical patient, the mammographer will discuss the results with the patient. And the RUC agreed that that was generally the case and that should be reimbursed more. So we actually did get a little bit of an increase, which is kind of unheard of in modern RUC times. Awesome. In general, we try to maintain the value, and sometimes you take a hit. And there's a lot of strategy involved. High volume codes that we do a lot of in our practices. So high volume, work harder to defend. And single view skull or something that's not as high volume.
So because now this isn't necessarily directly relating to an RVU, but it relates to the people that are probably going to listen to this this discussion. For YPS members or for RFS members, if they're interested in this topic, or they're interested in one day when they've had the accomplishments of Dr. Silva and they want to hold the radiology seat on the RUC, what's the intro position? And let's say they've already been with me on EAG and now they're ready to move on to the next step.
So the ACR has a RUC advisor. That's Kurt Shoppe right now. That's the person who prepares the arguments, who's kind of the lead of the RUC team. There's several of us that are on the RUC team. There's an alternate advisor and an advisor. The RUC advisor in general ascends to the RUC seat on the panel. Now that person, I didn't explain this very well the first time. So Dr. Silva he's not actually allowed to help the ACR argue our radiology points. He's supposed to be an unbiased participant on the panel. So all the people on that panel are listening to the arguments and voting. They obviously can't remove all their biases, but they're not supposed to promote any one specialty society's interests. So the person who's on the RUC panel seat really functions at a higher level of being one of the arbitrators of the value. The RUC advisor that Dr. Shoppe is really the one who's the top soldier of our team, basically presenting our arguments.
Gotcha. So this, and now I'm switching gears a little, but this was a question that was posed to me, and so I'm making it a point to get this out there. We're talking about RVU valuation, we're talking about the RUC. Have you all, or is there any discussion of AI efficiency? So if there's going to be an AI efficiency gain from implementing an algorithm, and would that down the road decrease the RVU valuation for a radiologist that was utilizing that tool if they got much faster?
Right, I think that's an excellent question. I think that's a really good thing that we're all kind of thinking about. So you're talking about if AI reduces the time that it takes for us to read a study, and then time is integrally related to how that RVU is calculated, are we going to see a big hit to our income? And the short answer is yes. I think ultimately there's no way around that. The cost of doing what we do is going to decrease. There's a couple of intricacies here. So one is that in theory, AI algorithms themselves will need to be reimbursed somehow. I don't think that practices are going to invest in these products if they don't have some way to prove value. So people have talked about making CPT codes, and some vendors have even asked for making CPT codes for certain AI algorithms. For instance, and one that helps you find MS lesions. Could you give that a CPT code and then actually bill for it in addition to the MR brain, like a base code and an add-on code? That gets really tricky. I'm not sure it's feasible in the current structure of the reimbursement system. I think you would have hundreds to thousands of CPT codes. It'd be really hard to track. It would be hard to determine what the typical patient was. I'm not sure that that's the best way to reimburse AI. So I think that finding a way to put a reimbursement on that on the current fee-for-service system is tricky for AI tools. The argument to what's going to happen to our reimbursement in the world of AI, if the cost of any individual procedure goes down, but we can do more, will our volume increase? And that, I think, is a question of what's going to happen to the demand. And if AI really makes us more efficient, if AI really gives us the ability to expand the population that we're imaging, and right now we're imaging most sick people. In my ER, I would say that we image every sick person in the general greater area that I live in. Right. Will we get to the point where we can image healthy people and add population health benefits to that? If AI is able to do that, then we may be making less per study, but we're doing a lot more studies in the same amount of time, and maybe our reimbursement doesn't go down. So I think there's a lot of questions, a lot of directions that can go, but you're absolutely right that the direct impact of a decrease in time would be a decrease in RVU and reimbursement.
And if I could just jump in and put in a plug for Dr. Golding's great work and the work of our really terrific economics team from the American College of Radiology. We have, I used to serve on the CPT editorial panel and saw everybody's economics team from the Specialty Society from the various specialty societies, and ours is really second to none. I mean, the types of things that Lauren just walked you through, that journey of how do we think about, these disruptive technologies and the impact on what radiologists' take-home pay is, are really the focus of ongoing strategic planning discussions by that group, really outlining each and every scenario that's out there. A lot of value added to all of us as ACR members from some really committed volunteers, and the overwhelming majority of people like Dr. Golding are volunteers that do this type of work. I mean, there's all sorts of scenarios that you play out. As I've been a peripheral participant in some of these, yes, if time goes down, sure, that's probably going to take a hit given the RVRVS methodology that she talked about. But as well, I mean, think about the explanation she just gave us all as the reason that valuation in diagnostic mammography went up, because we made a compelling case as radiologists, particularly our breast imaging colleagues, that they're really spending that time as the post-service work with the patients, talking with the referring physicians. And so, I always try to remind people as well, when people say, oh, is AI going to put us out of business or cut our payments? AI may be able to replace a lot of my interpretive work, but it's probably not going to be able to replace a lot of my pre-service work, which is the appropriateness of that study, and the post-service work, which is the communication, the contextualization of those findings. And so, reasons to not be on an RVU factory, just jump out, dictate out the cases, not develop those relationships, because those types of things could actually hurt us down the road when we start having to make cases for valuation outside of diminishing time on the intra-service work.
Thanks, Dr. Juzak. So I'm worried that I will forget to do this. I got some special eye candy here, that some of which is from Dr. Juzak's paper, some of which he sent to me in our discussions prior to the webinar. But I'm going to go through this, and this is this is a split between both part 1 and part 2. But I think the biggest strength here is when we start talking about this concept of the radiology practice productivity dashboard, and there's an example coming up of what that might look like. So we're segueing into that. I think we hit the national part, and then it'll give us a nice transition into how this, what this means for day-to-day practice. So here we go. We got a radiology practice productivity dashboard, figure 1. Dr. Juzak, what are we seeing here on this image?
Sure. Let me get back to my screen. Sorry.
No, I'm sorry. I put you on the spot. I'm sorry.
Up. No problem here. Got a browser clicking.
I'll say this. What we're seeing is we're seeing IRs listed because it's the center screen, and of course that's most relevant to me right now. And we're seeing them compared to one another in terms of their RVU production. And then we've got the other subspecialties on the left and the right with their RVU production ranked lowest to highest. So is this something that's being done in the private practice world? Is this something that's being done in the academic world to stratify our performance in RVUs?
I think it is, and I think, and it depends upon the sophistication of your practice with regard to what they're measuring, what you have the capabilities to measure, what are your priorities, and what do you want to do with them. But I think this is a graphical, perhaps a little bit more primitive version than what Lauren was talking about in her group, where they're comparing the people who do the Tuesday morning pediatric slot with the Tuesday morning pediatric slot. So this was one group, if I recall correctly, and I fictionalized the data, but either that Larry had worked with or I had worked with, that basically was looking for tools of graphically representing their radiologists, and sort of said, okay, we've got 15 body imagers in the group, or general radiologists, they called them body imagers, and here's the range of their productivity. Here's our interventionalists. The interventionalists, I mean, IR 25 years ago used to be the top dogs on RVUs, and IR's taken quite a bloodbath with, as a result of the bundling, which does get back to, one of my admonitions to people is, if you live by the RVUs, you could die by the RVUs, because that whole complicated horse trading process that Lauren just talked about that, there is that, if the sacrificial lamb of the rock on, a February meeting in Tucson is, we're going to take down, brain MRI, well, all of a sudden, poof, there goes your group's graphics. So anyway, what this group basically did is said, we're going to compare our mammographers to our breast imagers to our breast imagers, or neuroradiologists to our neuroradiologists. And that way, we're not saying, IR number 1, and, he or she is having a food fight with body imager number 15 there. We're going to say IR1 should be appropriately benchmarked with the pool of the 5 IRs. And then there's questions as to, well, you know what, maybe that person does more clinical work, and the other person's doing the embolization oncology work. So it's just a tool to be able to drill down and help explain the variations in the RVUs. Got it.
Look, can we move to a even more specific example? So here's another figure. So this is going to be an example of what somebody might get in practice as a summary of their work, as a summary of their RVUs. So how is this? How are we figuring out this kind of data? Like if you were in a group and you knew that you're over here on the left of this figure from your paper, your work RVUs per day, 43. Is that decided based on what was built? Like you generated reports, they went to your billing company or your back office billing company, you billed, and you calculated based on the CPT codes what the RVUs were. Is that how that's created?
Exactly. This is an average daily work RVU, which, is one important thing, is that if you are comparing people for RVUs, and I think RVUs should be part of your balanced scorecard. This is, much more primitive than, for example, our faculty balanced scorecard that we use right now. But again, this is, something from probably 10 or 15 years ago, actually 2009, so 10 years ago for this doc. So basically RVUs, if you're going to compare, me to one of my partners, you don't want to compare the fact that, okay, I've got more grant money and therefore I'm not on the clinical slot as much because I'm doing research and I'm never going to be able to keep up. You say on an average day, how many RVUs does Duzac day versus an average day of, Dr. X do? And so you want to correct them for day, particularly as we've got more people now that want to work part-time or work extra shifts. So I think normalizing it for the number of shifts, otherwise it's the denominator can really fudge the numbers quite a bit.
In my practice, we actually benchmark per hour. So we come up with this very complicated number of what your average RVU is per hour compared to your peer who's doing the same rotation on the same day. I'm not sure it's any different really than doing it by the day, but every practice has their own system of doing it. I think in general, it's not terribly toxic if you are comparing apples to apples. And then you have to, as Rich alluded to, account for non-clinical work, which I think was on the agenda at some point to talk about, but we can hold off on that if you prefer, Kyle.
So, two questions. One, and you touched on the non-clinical work, Dr. Duzac, with your mention of the grant funding, but it made me want to ask you, when you have this hourly RVU average or production, how do you see that? Do you see that on your PACS system, or do you see it as a report?
we get a quarterly report. In my group, every person gets a quarterly report, and it benchmarks you to the average, your equivalent of radiologist. You get a variance of your performance to the average, the fictional average rad, and you also would get a plot with our, how it goes 2 years back of quarters, so you can kind of see if you're up or down. So it's useful. You really only see yours, and a couple of leadership people in the practice see everybody's.
Gotcha. So you mentioned this, and it's I'd like to know your thoughts about it. What are your thoughts about our discussion of non-RVU producing work? And I'm going to give it a little bit of a definition. So Dr. Duzac mentioned grant funding. So not necessarily an RVU producing work. Other things that are on in clinical practice may be curbsiding, going over images that were produced at an outside hospital, reinterpretation of images, doing consults, performing consult work if it's not E&M billed. Where does that fit into? How do you prove your usefulness? How do you quantify all that work that's being done.
Yeah, I think for me that's probably the most most toxic part of using an RVU system in a practice is that there's so many other things that are practice building outside of just reading studies and going to hospital leadership meetings or doing ACR stuff, doing quality metrics, measuring things, working on your registry reporting. So a lot of things that go into it, and a lot of that stuff gets done after hours. But for people who are doing meetings during the day, you don't want to penalize them for doing that sort of thing. And there's a lot of there's all sorts of politics within practices of who thinks what's the most important. And in general, there's people in my practice who would hate going to meetings and would hate doing webinars and would hate doing all these other things. And then there's people that really like that and find a lot of professional satisfaction in that. And the goal is to get a practice that's a good enough mix of those different types of people that one supports the other. I think my advice as young professionals and new people looking for jobs is you can't show up on day one and say, hey, I want to be a practice leader and I want to go to hospital meetings, and so I'm not going to produce as much. You got to get in there and work your tail off and prove that you can be a really good radiologist and carry your weight. And maybe that requires doing a lot of the other stuff after hours. And then once you've proved yourself to your practice and proved your value and shown them that some of the other extracurricular stuff you're doing is valuable to the practice, that's when you can start kind of mentioning why your RVUs might not be as high as someone, or why you might want to get an admin day somewhere here and there. That's something I've struggled with a lot in my group. I'm relatively new to it's like my 4th year, I think, in the practice. We're really busy, so it's hard to justify any admin time off to go to the Rock or go to something. So for now, I'm doing it almost exclusively on vacation time. Hopefully, at some point, they'll realize that it's valuable and give me a couple of admin days here and there. But I think going in and asking for that right away is probably not the best way to get on the right foot. That being said, you have to find the right balance for you, and that may go into your decision on what type of practice you want, or whether you want to be an academic or a private practice setting, or even what style of private practice you want.
Well, not trying to speak for everyone, but I think this one's fair. We appreciate your contribution. And calling in too, so it helps us out quite a bit.
Yes, but would you take an extra week and call for me, Kyle? That's the question there.
No, definitely not. Dr. Duzak, one thing that you mentioned in your paper, and this ties in really well with what Dr. Golding was just talking about, is you read about RVUs in context of professionalism. You mentioned the 3 A's, being available, being able, being affable. And then you mentioned disruptive behavior, that I guess not personifying the 3 A's. Is there any way to quantify that work, or is it more of the same, where it's not a good RVU is not a good representation of that aspect of professionalism?
Yeah, basically, Kyle, while I'm chatting, maybe if you would be able to pull up that diagram that I had emailed you today, because I said if we were going to go that direction, I had a there. Yep. So here's sort of how, the font didn't quite roll over here, but here's sort of what I've become increasingly an advocate of, which is rather than creating an RVU-focused scorecard, to create a composite scorecard. And what your group may do in the practice you join may be very different from my group, for example. And so this is sort of an overall sort of a sketch of how we put ours together in our faculty plan. And admittedly, we're academics, where there's a scholarship component, there's an education component, there's the clinical service, which is your RVUs, but it's also, some quality metrics of your turnaround time, patient satisfaction scores, things like that. There's other service, where you're serving on the medical staff executive committee in a private practice, or the credentials committee, or, God help you if you're on your IRB. I mean, I used to serve on that, and it was just, it was just service work, because we had to have somebody, from the practice sort of put in their service time. I think actually the most fundamental piece of all of this is to create some sort of composite citizenship score, which is sort of the fudge factor for this, because, if you've got somebody that all your partners know is, that person's cherry picking the cases, they're not, returning the phone calls from the clinicians, they're annoying the technologists, things like that. they may be able to game the RVUs, but they're not going to game some sort of citizenship score that, for example, all the partners vote on each other for that, or, you know, in our academic practice, that our chair and somebody's division director together assign each of us a citizenship score as well. And so I think some sort of blended scorecard like that makes the most sense. You know, if you're in a private group, you may not have any education contribution, or you may be a radiology group, but there's, you know, medicine residents or something you have to teach. You should get some points for that. There may not be a scholarship piece. And what we actually do in our practice, and, you know, and I think some of this works in a private practice as well, is that if you're the group president, you know, we should, you know, count the weighting of your clinical service less, but dial up the expectation of more other service, that meeting, you know, meeting with the attorneys, the billing company, and things like that. And we do a similar thing, you know, in our academic practices. If you've got more grant money, that pulls you off the clinical schedule, but by golly, we're going to expect more publishables out of you for doing that. So I think looking at it conceptually like this makes a lot of sense. I'm a big believer, I mean, back to those 3 A's, or the professionalism, is there's got to be some citizenship correction for this, because otherwise you're going to have people that are just going to grab the RVUs and they're not going to do all the other important work that, you know, Dr. Golding's doing in her private practice, and I'm sure sitting, you know, going to these committee meetings and representing the group well, and, you know, and that buys you security with ongoing future attractive contracts with your health system.
Got it. Now, in this, with regard to the slides, I did update the, I mean, I did upload the following slides. Is it relevant here? Let me, here you're highlighting the aspect. So this is what you just discussed. I guess there was some content issues here. My apologies on that part. What is this, the fact that this last slide in most private practice, and it drops off the scholarship and education part, simply because it's just going to be harder to quantify. I guess it might not even be a part of some private practice. Is that about right?
I think so. I think the building blocks, Kyle, have to fit what your practice's mission is, what your practice's scope is, you know, and so, you know, the overwhelming majority of private practitioners, and, you know, Dr. Golding notwithstanding, because she's just been amazing, you know, with regard to service and, you know, to the profession, but also through some scholarship, are not writing papers. And so, you know, maybe if you do one a year in an average private practice, or you do a case study here and there, that may be your hobby. Maybe your group will reward that, but in most private practices, you know, you probably don't want to be scoring people for writing papers or lecturing at national meetings, because that's just not the expectation of what that group is. In those situations, I would argue you need to be dialing up you know, the other service. You know, everybody, by golly, should, you know, have a job in the group. They, you know, you need to have your macro person to sit there and, you know, help your group decide what are your quality metrics that you're going to be focusing on. You need somebody that's going to represent your group well, a credentials committee, and all those types of things. And everybody needs to be a citizen.
Yeah, that
Kyle,
makes total sense.
If any of you know Samir Patel, he's a radiologist in Indiana. He's done a lot of work in his private practice. He's developed this value matrix, is what he calls it, and he's published a lot about it. And it has very detailed item by item things that people in his practice do to add value and to provide service. And it's a very good and interesting resource to look at and think, you know, how can I do any of these things, or how should the people in my group be doing these things, and how can we quantify them? My group, as part of our RVU tracker, we had option was a drop-down menu where if you spent, you know, 20 minutes doing curbsides, or you did a tumor board, or you did something, you were supposed to track that time in the little drop-down menu. I'll be honest with you, no one uses it, because it takes time where you could be getting RVUs. You could be picking head CTs off the list and not working with the drop-down menu and categorizing how many minutes you'd spent doing something. So that hasn't really worked for us. Dr. Patel's group has done a good job at quantifying that, and then they have a piece of paper to hand to their hospital administrators and say, okay, we spent 50,200 hours on these types of work for your hospital, and that really makes them indispensable aside from just the contracts that they have. So that's probably useful to look up if you're interested in that for further reading.
Very, very interesting. One thing that's kind of dovetailing with that is, and some people posted question on this, closing the loop with, this is something that I'm reading, stuttered a bit. There's something I'm reading out of the question list here and trying to accommodate the questions that are posted. Thank you guys for posting questions where you have them. Closing the loop with the primary team. Let me see if I can get this right. So the question is, we close the loop with the primary team, but keep consulting other care teams involved in care for the same study. Is this accounted for in RVU pre-service? So I think this is more along that same concept of being a good citizen, and then wondering this RFS member is wondering how it's accounted, how it's measured.
Can you say that one more time, Kyle? Can you read the question again?
So we close the loop with the primary team, but keep consulting other care teams involved in the care for the same study. Is this accounted for in RVU pre-service?
So like you might give results to the internal medicine doctor, but then you still are communicating with the specialists later who want to come look at a study at a different time?
I think so. I think
okay.
so.
Yes, that would be accounted for in the post-service. So it's a general statement of communicating results to other providers, and that's an interesting statement that we've made sure that the RUC is aware that not only do we talk to, say, in the ER in a trauma case, we may talk to the ER doctor, but then we may also go over that exact same study with the trauma surgeons or the neurosurgeon, and we're trying to justify every minute that we've asked for in the post-service time. So that's a good question.
Got it. Well, I want to summarize.
One related, if I may, because I've heard a variation of that, which is, I have 3 studies a day where, my gosh, 5 people come on down and they want all this extra time. Can I bill out something extra for that? And that's all in that blended post-service work that Lauren just talked about. There are some people that are just insistent, gee, I had to talk to 3 people about this. I always, somewhat snarky respond back, well, then are you going to give extra money back to Medicare if you didn't have to take a phone call about a study? And, it's all part of the blended portfolio, and that's how those things are weighted when they get surveyed.
Yeah, that's a great point, Rich. So the codes are valued based on the typical patient, and typical is defined as 50% or more. So do you talk to 3 different clinicians on at least 50% or more of the cases you read? And if the answer is no, then you shouldn't get paid for it based on the way the system is structured. So he makes a good point that if you're going to have to give that money back on all the cases that you don't talk to 3 people, and especially ones that you don't talk to anybody, which honestly is somewhat the case.
Maybe we can have a special checkbox where we check. I talked to a clinical staff member, and I called multiple people and spent 15 minutes of non-overlapping time. Have you seen those kind of notes in the chart?
Yeah, from the ER especially.
Right. Let me summarize here, because in respect of everybody's time, we'll start to close this out. So we discussed during this webinar, we discussed 2 papers by Dr. Duzak, Measuring and Managing Radiologist Productivity. Dr. Duzak gave us a great overview of the RVU and some specifics beyond that. We talked about cherry picking. We talked about non-RVU producing work, and we discussed an overview of the RUC and how now in today's environment, how billing has changed, is changed, how it's negotiated, how the radiology members and other members of the RUC are surveyed for changes to reimbursement for certain radiology studies. So a really nice and broad overview of billing, and then focus down on RVUs and how it directly affects us in our clinical practice. I really appreciate the discussion. A couple of housekeeping things. We'll have one final question. I have one teed up here from an audience member. After that, we'll adjourn. I'll close out the session and then follow up. We will all follow up by an email correspondence to give you access to the video and a brief survey. If you would please fill out the survey. It gives us good information on what we need to do next time, what are things you're interested in hearing about, and that helps us with our content going forward. Okay, do you have any other commentary before I hit you with the last question, Dr. Duzak or Dr. Golding?
Fire away.
Okay,
hit us.
Here we go. So this is a good one. It's a long one. Should RVU also be complexity driven rather than solely modality driven. And he follows up with, it's often that a complicated CT can be more time intensive than a straightforward MRI. How can we best account for patient comorbidities, number of prior comparisons, and complexity of study?
Well, that is a complex question. So to some degree, intensity is accounted for in the valuation of studies. So you know, a CT neck or a CT face might have more RVUs than a MR head. I'm not sure exactly what the RVUs are. It's probably not true. But there's some relativity there based on complexity. And like I said before, intensity is absolutely a factor that is used to determine the RVUs. And it goes back to what I said earlier about the typical patient. So the only way that the RUC has to value things, they can't do it on a study-by-study basis. They have to do it on the typical patient. So if on average your brain MRI is done for a patient with a headache, then it needs to be valued for a patient with headache. And then unfortunately you lose money every time you read a MR on a person with MS and you're counting hundreds of lesions and trying to characterize those. But what they try to do is make an average value. And our job really on the RUC team is to try to not really work the system, but we really try to get payment for what we do. So we don't want to overlook things like making sure that we're accounting for looking through comparisons and looking at disparate packs for comparisons. A lot of us, I think it's typical that you might have to query a different system to see if there's outsides or spend extra minutes looking for comparison studies. Same thing with the discussing with referring physicians. We have to make sure that we're getting credit for that. But the way the system's structured, there really isn't a way to get paid for individual studies that you spend a long time on. It's really done by typicality in the current system. That may all change as we move more towards value-based care, and we're less paid on a per study basis, on a volume basis. And when we're paid to try to keep a population healthier, that all kind of gets turned up on its head. So that's just the way the system is now isn't necessarily the way it's going to be in 5 or 10 years.
Yeah, and if I can just add to that, and I think Lauren had a great explanation, but everybody always focuses with these questions on that those couple cases each day that are just the ones that just ruin your day. They take ridiculous amounts of time and say, I want more money for that. Again, this is supposed to be a typical case here, and you're getting paid if you're doing 50 cross-sectional imaging studies a day. You want to get paid an extra 50% for those 3 that were really hard. Well, yeah, but remember the process then, you also had a few that were just really straightforward. Are you going to give money back? Are you going to say, you know what, I'll be willing to take less money? And it is a blended payment, but I think it does highlight, particularly in light of, our discussion of cherry picking, if I'm in the group and I'm, I'll read, sure, a few normal kitty chests from the ER, but you know what, if there's a really goofy congenital something chest and I'm going to give it to Dr. Golding to read, that's where the system breaks down. It was never designed for that. It was designed as a national payment system. There are some methods. I mean, just, I think there are some potential solutions. One of our partners at Emory's working with me, Adam Prater, on looking at machine learning algorithms. Can we pull out of reports a variety of complexity factors? Did that patient have, multiple outside studies prior? Were there multiple related clinical encounters? Probably some sort of benchmarking tool. Definitely not ready for prime time, but I think if we were going to be using these as tracking tools, we need something much more sophisticated than the RVU to help us.
Yeah, that totally makes sense. It was a good final question because it opened a concept that I think that I didn't fully understand, or at least certainly understand a little better now, which is the blended payment concept of there. It's supposedly RVUs the RVU is a portion such that it accounts for the very difficult CT case and also the quicker CT case. Is that a fair summary?
Yeah, that's correct. And if you get in these surveys, the surveys for the RUC are sent out to random ACR members. When you're filling out the times, we always have a few people every time we do this who I guess are very proud of how fast they can read, and they'll put that they can read a head CT in 30 seconds. So keep that typical blended ratio in your head if you get one of these. So think about the hardest patient, the kind of what's average. Don't try to brag about how fast you can read them. That's my plug for the survey. Good
information to have in case I get one of them. Well, Dr. Golding and Dr. Duzak, again, thank you very much. And to the attendees, thank you for joining us. Hope this session, answered the questions you were hoping to ask. If you have questions and follow-up, feel free to tweet them to me or to Nate Coleman, or our panelists are actually both very active on Twitter, so you could just tweet it to them directly, and include the AACR RFS tag in there, hashtag in there, so everybody else can benefit from your insight. Well, thank you very much, and I hope everyone has a good evening. We're going to go ahead and sign off.